Hello everyone. I'm Tammy Bennett, the Reproductive Health Statewide Nurse Consultant for Louisiana. In my role, I work to increase access to quality health care for reproductive health and also to improve health outcomes for men, women, and families in Louisiana. Part of our initiatives are to provide community providers with training, technical assistance, and quality improvement work for their clinics.
Hello everyone, my name is Kara McCarthy and I am the Reproductive Health Integration Program Monitor. I work with community health centers to help them build their capacity to provide high quality reproductive health services.
So in this webinar, we'll be sharing information on the birth control methods on the market, specifically their effectiveness, how they work to prevent pregnancy, the pros and cons of using each method, including any possible side effects. This information is important to have no matter what your role is in providing sexual and reproductive health care to individuals in your community. So at the end of this webinar, I will also share a number of resources you can access to keep learning about birth control methods and enhance your knowledge when working with patients. All right, let's get started. Kara does not have any disclosures. However, I do need to disclose I am a speaker and a clinical trainer for both Merck and Bayer companies.
All right, so our objectives today are going to be to describe why the U.S. medical eligibility criteria and selected practice recommendations are used in a contraceptive visit. We're going to talk about the birth control methods currently on the market from most to least effective, and we'll be going through each method. We are going to describe how each method works to prevent pregnancy, and we're going to list the pros and cons of each method, including possible side effects. So before we get started with the different methods, we wanted to talk a little bit about the conversation that you can have with clients to bring up the topic of pregnancy prevention. And so when we're working with clients, we like to use this PATH approach. And PATH is an acronym for pregnancy attitudes, timing, and how important is pregnancy prevention. And we really think that this is an important approach because it helps to provide sexual and reproductive health care services in a client-centered way, and it helps our clients explore their goals and needs when it comes to pregnancy prevention. So we'll be talking about PATH in the next few slides, and again, this is designed to elicit information in a way that leads to client-centered conversations. So breaking down the different elements of PATH, the first question you could ask about pregnancy attitudes might be, do you think you might like to have children or have more children at some point? So this would be your introductory question when you're talking about getting into the conversation about pregnancy prevention. Your client may answer yes, and if so, you would want to probe a little bit deeper with the timing question. So you would ask something like, when do you think that might be? The client may give a specific time frame, such as in the next few months or in the next few years, or it may be related to a life event, such as after college graduation or after getting married. In any case, though, this question, the answer to this question could really help you know not only what the contraceptive needs are of your client currently, but also what preconception resources you could offer. So you could follow up by saying something like, I'm available to answer any questions you may have about getting pregnant. Or if someone said, maybe I'm not sure, you could say something like, since you said you weren't sure, would you like to talk about ways to be prepared for a healthy pregnancy? So again, this is a really helpful question to get at both contraceptive needs and also maybe some preconception needs if someone is planning a pregnancy at some point. The next question you'll want to ask for both people who are planning a pregnancy at some point and those who answered no to the question about pregnancy attitudes would be, how important is it to prevent pregnancy, period, or to prevent pregnancy until that planned pregnancy? And this is also a really important question because it's going to elicit a lot of useful information for the client as they're able to talk through what their priorities and their desires are, but also for you to help guide you to that next stage of having that conversation about contraception. So it also gives them an opportunity to talk a little bit about what it might be like, what the impact might be on their life if a pregnancy did occur. And that often when people are thinking of it in kind of that real world sense, it helps to clarify some of those priorities of, maybe using a more effective method versus a less effective method. Again, it's really helpful as a natural transition if someone's talking about pre-pregnancy care, so you know what to direct them to in that sense. And finally, if they are looking for pregnancy prevention, will allow the conversation to shift into what the needs are for the client. And so we know that throughout this conversation, we want to remain aware that the decision to use or not use contraception is very personal, and it's not always easy. There are a lot of different factors that can impact a person's decision to use contraception, including compatibility with their culture, religion, values, and beliefs. It could be impacted by how convenient the method is, and that could be, is it something that needs to be taken every day or every few months? Is it something they can buy over the counter, or do they need a prescription? Cost always comes into play. And there are a lot of different ways to reduce the cost of birth control methods that we can talk about at a later date, but for some of the methods, this can be a barrier. Discretion is also important. So is it something that the client would like to keep private? So using something like the injection, which there's no sign of it, or if discretion isn't an issue, using something like the patch could be an option. Side effects are definitely important, and Tammy will be talking later about a little bit more in detail of some of the side effects of the methods that we're going to be discussing. Acceptability with sexual partners is also important. Whenever possible, we want to encourage our clients to be able to have these conversations with their partners. Ultimately, we know it's the decision of the client themselves, but it can be helpful to have that conversation as part of this larger conversation about how supportive a partner may or may not be. And then finally, fit with lifestyle. So how, again, does this fit into this person's life? Is it something that they can do every day? Is it something they need, something a little bit easier to manage? All of these different aspects will help. Talking with the patient through all of these different aspects will really help them start to hone in on maybe what method might work best for them. And so as we get into the next section, we just wanted to start by saying, it's very important for us to make sure we're looking at the evidence-based guidelines when it comes to contraceptive use. So we want to make sure that the family planning practices that we're using are based on the best available evidence. And like Tammy said, we'll have some resources at the end to share with you that will give you some more information about these best practices. We want to make sure too that we know how to address misconceptions that are out there about using contraception, about the safety of some contraceptive methods. So we'll do some myth busting a little bit later. We want to make sure we remove any unnecessary medical barriers. So this could be any maybe prerequisites for contraceptive use that may not be necessary for certain methods. And ultimately, we want to improve the access and quality of care in family planning and reproductive health. So again, we'll be talking about this a lot more in future presentations, but we just wanted to make sure that right from the start, that these are the guidelines that are very important for us. And then finally, we wanted to talk just briefly, and we'll talk a little bit more about dual protection a little bit later on, but just putting this idea out there of, if preventing pregnancy is really important to you, and if preventing sexually transmitted infections and HIV is very important, then this idea of dual protection really is something that you should discuss with your client. So a birth control method, especially the hormonal methods, won't offer any protection against sexually transmitted infections or diseases. And so it's really important to talk to the client about also using a barrier method. And this is what's considered the gold standard when it comes to preventing both pregnancy and sexually transmitted infections. And now I'll pass it on to Tammy to lead us through the different methods.
So thank you, Kara. We're going to do this a little backwards on my section. Usually you have resources at the very back or the end of the presentation, but I do want to go through a couple of resources that is extremely important to use whenever you're talking about making sure any method that you choose or you talk to with your patient to help her choose the best method for her is actually a safe method for her. So one of the great resources that we have available is the U.S. Medical Eligibility Criteria. And you can actually download this app onto your smartphone or Android, which is very convenient. And if the patient has any of the chronic illnesses or syndromes, you can look this up. For instance, hypertension or, migraines with aura or without aura. You can look these up and you can determine based on a color and number code how safe each method is for a person with those conditions. So that's our primary goal, is to make sure whatever method the patient desires that she feels like would be best for her is actually a safe method. And the second thing with that is the US SPR. And what that is listing of all of the different methods, and it tells you how to start that method and if you need backup birth control, if you do, for how long. And so that's also very good when initiating different methods of birth control. Here is just a little bit more about that. Safe use of contraceptive methods by men and women with certain characteristics and medical conditions. And all healthcare providers use these guidelines in order to safely prescribe methods. It has more than 1,800 recommendations for over 60 conditions. So it's a very, very important resource, and it's not something that we usually memorize. It's something that we need to have very handy in order to help our patients. We'll also be going through how to be reasonably certain a woman's not pregnant guidelines, when to start, and follow-up and management. So as I said, there's 4 color-coded categories in the medical eligibility criteria. And number 1 means, hey, there's no restriction. This client can use this method without any problems. And number 2 is advantages of using this method generally outweigh the theoretical or proven risks. So 1s and 2s, we're good. 3s, however, require a little more caution. So theoretical or proven risk of the method usually outweigh the advantages. Usually not recommended to use this method with a person with this illness unless more appropriate methods are not available or acceptable. And then a 4, you can see that's in red, it's unacceptable health risk if the contraceptive method is used by a woman with that condition. So let's go through just how to use this, because it's that important. Here is a person who has headaches. And so if you can see that the patient has a history of migraine without aura, then they can use any of the methods that are listed at the top here, which I cut off actually. This is like IUDs. This is hormonal, non-hormonal IUDs. This is Progestin-Only birth control pills, followed by others. And then if you get to a 4, you need to look in that column and see what not to use. So if you have with aura, and then this would be the combination oral contraceptives here. The next thing we're going to talk about just real briefly is how to be reasonably certain a woman's not pregnant. We use this criteria and guideline whenever we need to find out if we can do same day start. Like if a patient comes in and they want an IUD, we have to be reasonably certain a woman is not pregnant. So in this case, we would go through these criteria, and if they meet any one of them, then we can be reasonably certain and we can go ahead and start that method that day. That's why so many patients are able to get same-day insertion of IUDs as well as implants, same day starting on, pills, patches, whatever. So this is very good criteria to keep up with, and I actually have it mounted on each of our exam room walls, so it's easy to and within reach to see. So let's go through a couple scenarios. The first scenario is an 18-year-old freshman who wants birth control pills. Her last period was on time and normal 6 days ago. She had sex 2 weeks ago with a condom, and she has a history of migraines without aura. All right, so let's run through this. So again, let's look and see, is there any way she could be pregnant? Okay, she had it 6 days ago. So her last period was normal, and it was less than or equal to 7 days. So she meets, you can put a big check mark on that. She meets that how to be reasonably certain a woman's not pregnant criteria. So we can start whatever method we want to today. Now let's look at her health conditions. She has headaches, migraines without aura, and she wants combination hormonal contraceptives. That is at level 2. And so she can have those safely. However, if she did have with aura migraines, that would be a 4, and you would not want to use those. So that is how you use both of those things together. And then the selected practice recommendations, the SPR, that tells you when to start the method. So we can start that method the same day, and then it'll tell you if you need to use a backup method. And since she is over 5 days since starting her cycle, she will need to use a backup method for the next 7 days. So it makes it really easy when you use these tools together. It also says the examinations and tests that are needed before initiating the combined hormonal contraceptives. So anybody, so when you look in this SPR, anybody who's getting a hormone of estrogen, you will want to have a baseline blood pressure, because we know that estrogen can increase your blood pressure in some instances. So this is another handy resource. So let's get into the methods of contraception now. There are intrauterine devices, those that do not have any hormones in them, that are the copper, which is also called Paragard, and it looks like this. You have those that do have hormone inside the IUDs here in this little middle barrel here, and there's several different types of IUDs that have varying amounts of levonorgestrel that's released into the inside of the uterus. Then you have the implant, which has progestin that is slowly released underneath the skin. You have medroxyprogesterone acetate, which is also known as Depo-Provera. And I'll make a little side note, you have an IM form of that, which is intramuscular injection. Plus you have a sub-Q opportunity that if your patients wish to self-inject at home, that is another option. Same medicine, a little different dosage and a different route. You have Progestin-Only Pills, and then you have combined hormonal contraceptions which contain estrogen. The last is emergency contraception, which is used as soon as possible after unprotected sex or after a risky event for pregnancy. You can take that to try to stop the egg from releasing. When you're doing contraceptive counseling, one of the main things we want to know is, well, how well does this birth control work? Most people don't want to take a birth control if they know that it's not going to work well. That's the whole reason why we're taking it. So usually we do let the patient know of each of these methods and where they are in the efficacy range. Any of these top levels will have less than 1 in 100 women who get pregnant while using one of these methods. In the middle tier, you're going to have 6 to 9 women who get pregnant out of 100. And then in this bottom tier, you can see it's not near as effective, where you have 12 to 24 in 100 women that will get pregnant using one of these methods. You're going to see 2 different types of effectiveness rate. One is perfect use. That means you have not skipped a pill, you have not missed a pill, you've not been late on a pill, you've not been late on your depot shot. That's 100% accuracy when using any method. However, we know that life happens, and sometimes this is the more actual use, which reflects what really happens in the real world when we factor in human error, not being able to get into the clinic on time, that kind of thing. Again, this is the US MEC and SPR. You can get to it online, but this is what the app looks like. So when you download it to your phone, you click MEC by condition, and then you pick the condition, or you can pick the method, or you can pick when the selected practice criteria, where you can click this and then say intrauterine contraception, and it'll tell you when you can start it, or if you're going to need a backup method. Again, the most effective methods are the implant, the IUDs, and then male or female sterilization. Let's talk about each one of these individually. The first is the copper IUD. And the reason why a lot of people like this is because it is non-hormonal and it lasts for 10 years. It works by stopping the sperm from reaching the egg. So if the sperm does not ever reach the egg, therefore there's no fertilization. You use it by going to the provider, and the provider will counsel the patient, see if that's what they need, sign consents, and then the T-shaped device is inserted up into the uterus, into the top of the uterus. The strings come out through the cervix, but do not come out of the body like a tampon string. It's way up in there near the cervix where the strings are. Perfect use is over 99% effective, and because there's no human error involved in this method, the typical use is the same as the perfect use, 99%. The pros, well, it lasts for 10 years, but it's immediately reversible. So let's say that the patient wants to get pregnant after about 4 years. She goes into her provider. The provider just gently pulls on these strings. These arms fold up and it comes right out. And then there's no medicines that have to wear off. She's immediately just as fertile as she would have been if she wouldn't have had anything to begin with. You can also use this while you're breastfeeding as well. So it does not have anything to do with the milk production. Some of the cons with this IUD being copper and no hormones, you may have a little more bleeding, cramping, and spotting when you first get it put in. It usually resolves over the next 2 to 3 months, but some women continue to have increased cramping and bleeding as long as they have this in there. So this probably would not be a method that I would recommend for someone who has very heavy, difficult periods. It also does not provide any protection against STIs or HIV, and it needs to be removed by a provider. The next one we're going to talk about is the hormonal IUD, and there's many different brands. Some of them that you may have heard of is Mirena, Skyla, Liletta, Kylena. It also works by stopping the sperm from reaching the egg. So if the sperm doesn't reach the egg, no fertilization. It is a T-shaped device inserted in the office, just like the copper one. It also is over 99% effective, which is great. The pros. Different brands of IUDs have different lengths, but most of them will work 3 to 5 years. We actually have Kylena, which is approved for longer. It is still reversible. So again, if a woman wants to get pregnant, pull that thing out, and within a few days to a week, it's like she had nothing there. This kind of IUD reduces cramping and bleeding. These are frequently used for women who do have difficult periods, bleeding, cramping, to lessen the amount of accumulation of the endometrial lining that has to be shed. So the less lining that has to be shed, the less bleeding and cramping you'll have. You can also use this in breastfeeding. It does not interfere with the milk production at all. So the cons, Well, I don't know if this is a con or not, but some women want to have normal periods. And in some women, when you have this in place, it can be so light, or sometimes you just have spotting, and sometimes you don't have periods at all. So if a woman wants to have a regular, normal period every month, this might not be the method that I would recommend. Do not provide protection against any STIs or HIV, and the provider must remove the IUD when they're ready for it to come out. So let's talk about the implant next. The implant is marketed under the name of Nexplanon, so you may have heard that. It works also by preventing the ovaries from releasing the egg, as well as thickening the cervical mucus, which prevents sperm from entering into the uterus. It is placed in the office by the provider. The provider numbs up the skin and inserts the rod right under the skin, and the provider has to be trained by the company before this can be done. Perfect use is over 99%, and because there's no human error involved, it's the same as perfect use. The pros, well, it works for up to 3 years. It's also reversible, so if the patient wants to get pregnant before the end of 3 years, you can numb this up, remove it, and within 5 days, all of the medication is gone from the system, and they will be just as fertile as they were prior to the insertion. It reduces the cramping because it also reduces the amount of lining in the uterus. It also is safe for breastfeeding. One of the major cons that we see is whenever you first put this in, you can have some irregular bleeding, some spotting or bleeding that may last for 3 to 6 months. Usually after the first 6 months, it normalizes, and some women don't have a period at all while they have this in. This also does not provide any protection against STIs or HIV, and it must be removed by a provider. So when we're talking about bleeding and the bleeding profiles for all of those top tier methods, you can see that with Paragard and Mirena, you spot for the first 6 months, and Skyla. But then the Paragard, your bleeding may continue to be heavier or longer. But usually with the hormonal IUDs, you're going to have lighter periods, and sometimes, especially with the Mirena, 30% of all women will stop having a period altogether. With the Nexplanon, you have unpredictable bleeding and spotting, but overall you're going to have a lighter period, and even 20% stop having their period altogether. Sometimes though, it just takes about 3 to 6 months for the body to get used to it, and then it'll be a lighter, if at all, period. Many times when we're counseling patients, we're going to hear myths. So let's talk about a couple of myths that you may hear about with your patients and how you can give them the true evidence behind the way that this works. So the first myth is adolescents and nulliparous women are not appropriate candidates for IUDs. And the fact is that actually adolescents and nulliparous women can be offered any of the long-acting reversible contraceptive methods, including IUDs. Both are in the medical eligibility criteria classification of a number 2, which means the advantages outweigh the risk. IUDs and implants have the highest effectiveness, continuation rates, and user satisfaction of all reversible methods. I will say that there are certain IUDs, for instance, the Skyla and the Kylena, which are smaller and are sometimes easier to get in nulliparous and adolescent women. So there are options out there that can be used. Another myth is IUDs can cause infertility. And the fact is that IUDs do not cause infertility, nor do they make it harder to conceive in the future. We do want to make sure that we treat any underlying STIs that a woman may have. Another thing that we used to do way in the past was we would have to make sure that they had, gonorrhea, chlamydia cultures on the chart, and we wouldn't put in an IUD until we had those, and that's no longer done either. We can go ahead and put in an IUD while we're sending off the testing for gonorrhea and chlamydia, so that can go ahead and be done. And if they have gonorrhea and chlamydia, we're going to go ahead and treat them when those lab tests come back. The only thing we would not want to do is put in an IUD if they have an obvious active infection. So as long as the cervix looks okay, we can send off those cultures and go ahead and put in the IUD. STI testing should be performed, but it can be performed at the time of insertion. Another myth is IUDs cause ectopic pregnancy. The fact is that IUDs do not cause ectopic pregnancy. Any pregnancy could be ectopic, and in the unlikely event of a pregnancy while using an IUD, her chances of having an ectopic while using an IUD may be increased. However, the chance of having a pregnancy with the IUD in place is so very low, so the overall risk of ectopic pregnancy is greatly reduced as compared to not using any contraception at all. Another myth is a woman who has had an ectopic pregnancy should not use an IUD. The fact is that women who have had ectopic pregnancies can use IUDs. IUDs decrease the absolute risk of ectopic pregnancy whether a woman has had an ectopic pregnancy before or not. Since the chance of becoming pregnant with an IUD is so low, the overall risk of having an ectopic pregnancy is greatly reduced while using an IUD as compared to not using any contraceptive method. If a woman uses an IUD and develops an STI or pelvic inflammatory disease, the IUD should be removed immediately. That is the myth. The fact, however, is that if a woman is using an IUD and develops an STI or PID, she should be treated with the antibiotics right away and keep the device in place. We're going to recheck her in about 3 days, and we're going to make sure she's getting better. If the symptoms do not improve within that time, at that point, the device should be removed. But initially, it does not have to be removed. We're going to go ahead and give her antibiotics. But watch her closely to make sure she does improve. Now let's talk about moderately effective methods. The first we're going to talk about is the Depo-Provera or medroxyprogesterone acetate injection. The way that it works is it prevents the ovaries from releasing the egg. It also thickens the cervical mucus, which prevents the sperm from entering the uterus. It is administered every 3 months by a trained healthcare provider. Now, one caveat to that is we usually give it every 13 weeks, and the intramuscular injection is given by a healthcare provider. There is a new Depo Sub-Q 104, which is 104 milligrams of Depo-Provera, and it comes in a Sub-Q package where the patient can give it to themselves, very similar to, training patients to give insulin injections themselves or other self-administered injections. Depo is very possible to be given by the patient. Perfect use is 99%. But we also see this is on the intramuscular where they have to come in and get the Depo. Typical use is about 94% because sometimes women are late coming in for their shots, can't get off work, etc. The pros is the medication is 1 shot every 13 weeks. You don't have to do anything before sex. It decreases your periods. Now, sometimes you have some irregular bleeding for about 3 months, but then a lot of women don't have periods at all as long as they take this. It's discreet. It can be used whenever you're breastfeeding, and there's no estrogen. So a lot of women who have health issues where they can't take estrogen, they can take Depo-Provera. Some of the cons I already mentioned briefly the spotting that can occur for the first 3 months, which usually resolves after they get their second shot. Weight gain, depression, hair or skin changes, and reduced sex drive are other cons that you may see for side effects. And it does not provide any protection against STIs or HIV. A hormonal ring that goes into the vagina. Its brand name is called NuvaRing, and it works by preventing the ovaries from releasing the egg, thickens the cervical mucus, and so therefore the sperm can't get up into the uterus. The woman will insert the ring into the vagina, and it'll stay there inside the vagina for 3 weeks. And then at the end of 3 weeks, the woman will hook her finger on it, pull it out. It's removed for a week, and then she puts a new one in place. The perfect use is 99% effective, whereas typical use is 92% effective. And that could be because the ring falls out, they take it out, forget to put it back in, you know, that kind of thing. The pros is that it can be left up in the top of the vagina for 3 weeks. It's discreet. There's nothing to do before sex, and it can make your periods regular and less painful. The cons is it is a foreign body in the vagina, so it may increase vaginal discharge. You may have a little spotting, and it does not provide any protection against STIs or HIV. The next one we're going to talk about is transdermal contraceptive patch. This used to be known as Ortho-Evra. It was the brand name. Now it's Xulane. It works also by preventing the ovaries from releasing the eggs and thickens the cervical mucus so that the two cannot meet. You apply this as a patch to the abdomen, buttocks, lower back, the upper outer arm, or the upper torso each week for 3 weeks. So it stays on 1 week, then you remove it, put on another one for the second week, remove it, and then put another one on for the 3rd week. At the 4th week, you leave all patches off and you have your cycle. It's 99% effective, and then typical use is 92% effective. The good thing is it's left in place for 1 week at a time. There's nothing to do before sex, and it can make your periods more regular and less painful. The cons, you can have some irregular spotting for the first couple months. Another con is it may irritate, the skin adhesive may irritate your skin, and so not all women can use it. And also, it does not provide protection against STIs or HIV. Oral contraceptive pills. So we're going to talk about the combination oral contraceptives first, and those are the ones that contain estrogen and progestin. These work by preventing the ovaries from releasing the egg and thickens the cervical mucus as well. How to use, it's something that you have to do every day. You have to take a pill every day at the same time every day. The perfect use is 99% effective, but typical use is 92%, because maybe we forget some pills or don't take them every day. The pros is it's nothing, you don't have to do anything right before sex. It can also make your periods more regular, lighter, and less painful. So sometimes we use these pills for adolescents as well who are having really difficult periods to make it a little lighter. You can also improve PMS, symptoms, and acne, and it helps protect against ovarian cancer. The cons is it may have, because it's stomach, it goes into the stomach and it has to be absorbed, you may have some nausea, some weight gain, headaches, changes in your sex drive. You could have some transient spotting for the first couple months, and then it does not provide any protection against STDs or HIV. So a little different pill that we're talking about now is going to be progestin-only. This does not contain estrogen, so it would be safe for those who maybe have some medical conditions that they cannot take estrogen. It prevents the ovaries from releasing the egg, also thickens the cervical mucus. This is less forgiving than the combination oral contraceptive. You must take this one at the same time every day. If you even delay by 4 to 6 hours, it could have an effect on you getting pregnant. So that's part of the counseling, is this one is very strict. You have to take it same time every day. Perfect use is 99% effective. Typical use, 92%. It is safe for women who cannot take estrogen and who are breastfeeding, and it may reduce menstrual cramps. It may also improve PMS symptoms. The cons, you could have some irregular bleeding or spotting, depression, hair and skin changes, and a decrease in your sex drive. Does not provide any protection against STDs and HIV. All right, Kara is now going to talk about the least effective methods.
All right, so now we'll talk about the final tier in those 3 tiers that we showed you earlier, which is the least effective. So these methods could be widely used, but it's important that we talk about how effective they could be and ways to make them maybe more effective. So we'll start with withdrawal, also known as Coitus Interruptus. This works by pulling the penis out of the vagina before ejaculation. It has to be done before ejaculation, though, and you have to make sure that the ejaculate is away from your partner's genitals, because even a little bit of semen could, or that ejaculate could, cause a pregnancy. Because of this, it is only 73% effective, and that's typical use, again, taking into account human error. So looking at the pros and cons, it's free and always available, which is great. There aren't any side effects, obviously, there's no hormones involved, but it can be really hard to actually pull out in time. So especially with, maybe some of our adolescents or younger people who are new to having sex and maybe not as in control, it can be a little bit harder to know when to pull out effectively. And of course, it does not provide any protection against STIs or HIV. Next is the diaphragm. So this method has been around for a while. It's a barrier that covers the cervix. You need to use it with spermicide, so you can use either cream or gel. And you use it by inserting it 2 hours before sex. So you need to make sure it's there long enough to make sure the spermicide is fully engaged. And you can leave it in for a long time, up to 6 hours after sex. And actually, you do want to leave it in place because, again, you want to make sure that that spermicide has time to work. So this can be a little bit nicer for people that don't want to do something right at the onset of sex and then right after. So you can have a little bit more time to just relax. Perfect use is going to be 94%, typical use 88%. And some of the factors that could contribute to that typical use is not using spermicide or weight changes that would cause the fit to be different. This method does need it to be fit by a medical provider because it comes in a lot of different sizes. And something like weight loss can affect that and make it not fit as tightly so that it's not providing a perfect seal. So again, the pros for this are that, again, it doesn't interrupt sex and there are no hormones. It gives the person preventing pregnancy a lot of control over the use of the method. It lasts a long time. They're pretty durable, but again, you do want to get refitted if you have a pregnancy or if you have a weight loss or gain. The cons could be that you have to use it every time you have sex, and you have to use it correctly. It can take some practice learning how to insert and remove, and so it's something that when you're fit at the health center, you're going to have an opportunity to practice with the provider there so that you can make any adjustments that you might need to make. And again, this one does not prevent sexually transmitted infections or HIV. Fertility awareness method, there are actually a few different fertility awareness-based methods available. What this is basically doing, though, is you're tracking your menstrual cycle so that you know when those fertile periods are, when the egg is being released, and you know how to prevent sex that could result in a pregnancy during those times. So you usually will be tracking your period, and then during those times using either another method such as condoms, or with abstaining from sex during that time. So this one also takes a lot of practice and really diligent tracking. Because of that and the human error involved, it could be about 76% effective. It's also important to note that this method can work well for people who are trying to achieve a pregnancy, because one of the pros is you get to learn about your fertility. And so through tracking your cycle on an ongoing basis, you start to learn where those fertile periods are. So based on what your needs are, you can either use that time to protect or try extra hard. This can be free if you're using like a calendar method, but there also are apps, and these things on the slide here are called cycle beads. And those are just other ways to help you remember to track your period and your cycle. There are no side effects. Again, you're just watching and observing what your cycle normally is like. But it doesn't work if you have irregular menstrual cycles. So this is a method that you would want to be tracking your cycle for a few months to make sure that it is within a certain date range. If you have shorter cycles or longer cycles, it can be harder to determine when that fertile period is. So this is something you want to track a few months before really relying on it. It does require the cooperation of your partner, especially if you're going to abstain during those periods, or abstain from sex that could result in pregnancy. And again, it does not provide protection against STIs, HIV. And finally, we wanted to talk about condoms. So this is our go-to barrier method, and we can talk about internal condom or female condom or the external condom that work by putting up a physical barrier so that the sperm cannot meet up with the egg and cause pregnancy. So you would use this if we're using an external condom, wanting to make sure that the penis is erect when you place the condom, and that after sex you remove the penis while it's still hard to remove the condom. With the internal condom, you can put it in a few hours ahead of time and leave it in a few hours after. Oh, dang it, Tammy. I'm gonna start again. Okay, we're doing so well. And finally, we wanted to talk about the condom, or more generally, barrier methods. So condoms work by physically putting up a barrier between the sperm and its access to the eggs, which could cause a pregnancy. So this is used by putting on a condom before sex. And in the case of an external condom, or sometimes known as a male condom, removing the penis right after sex while it's still hard, so that the condom can be removed without spilling any of the semen. If you're using an internal condom, sometimes known as a female condom, you can put that on in advance of sex, and then just be very careful after sex to remove the condom from the vagina without spilling the sperm. So that's one thing that you want to be really careful about, and which could lead to the typical use being less effective than the perfect use. Perfect use, of course, is going to be used new condom every time. And important to note that you do not want to use an internal and an external condom together, because even though that sounds like dual protection, it could actually cause either of the condoms to break. So pros for this. It does protect against STIs and HIV. So again, when we talked earlier about that dual protection and about the gold standard, you could be using a hormonal method for the pregnancy prevention, and then a condom for your STI, HIV prevention. So that's really important. They can be inexpensive or sometimes free if you know where to get free condoms. Very convenient. It adds all that extra prevention to your other methods. And there are generally no side effects, although if you have an allergy to latex, that can cause some irritation, and so you definitely don't want to be using a latex condom. But there are other types of condoms out there, such as the internal condom, which is actually non-latex, so that could be another option. And of course, the cons, you do have to be very diligent and use it every time. They can take some getting used to. So if you're new to using condoms, sometimes practicing on your own to help you become more familiar with how to put them on correctly and how to remove them correctly. And you usually have to have partner participation to make sure that both people are on the same page. And so with that, we have wrapped up our presentation on the different methods, and I'll let Tammy take us through the different resources that are available.
So now we have the resource page, and I do want to let you know that all of these resources will be referenced as well onto the Moodle platform to make it very easy for you to reference. So we have the Reproductive Health Program for Louisiana's website, National Family Planning Training Center, Bedsider, CDC, the Guttmacher Institute, Reproductive Health Access Project, along with ACOG, and then the PATH framework. And I want to thank you all for listening in today. Please know you can reach out to either myself or Kara if you have any questions or need any clarification. You'll have a great day.